Kia ora, and welcome to part two of this look into respiratory assessment and the use of respiratory status assessment tools. So in part one, we looked at the difference between someone that presents with respiratory distress and someone that may be in respiratory failure. And we looked at the use of the vital signs and some of the pulmonary markers. So in this part, we'll be looking at the clinical examination skills that are used as part of the respiratory assessment. So let's crack on with that. The clinical examination of the respiratory system tends to have three separate phases. The first is observation, the second auscultation, and the third percussion. Or in other words, a look, a listen, and a feel component to the assessment. Under normal circumstances, the chest is symmetrical, and so is the movement of inhalation and exhalation. In other words, the left and right sides of the chest mirror each other in terms of shape and movement. Now, alteration of this can occur when the pleura has been interrupted and a lung collapses. It's a subtle change and is best viewed when a patient is in a supine position and the observer is standing at their feet looking up the length of the body. Another thing we can observe is respiratory pattern. Under normal circumstances, inhalation is brief and an active process, while exhalation is a passive process and takes a little longer to complete. The normal relationship or the ratio between inspiration and exhalation is about 1 to 3. Faster respiratory rates alter this ratio, and as breathing becomes faster, the exhalation phase becomes more and more active as muscles are recruited to assist in shifting air out of the chest, and the ratio can fall to 1 to 2 or even 1 to 1. The ratio can also be lengthened, and this is very typical in asthma. As the airway resistance increases as the person breathes out, it takes longer and longer to force the air out. So despite there being active recruitment of the accessory muscles of exhalation, the time taken to exhale becomes longer and longer to cause the exhalation to inhalation ratio to extend. And the second thing that we can observe is that the muscles and the posture that the person uses are going to assist the breathing out phase. Other changes in patterns of breathing that we could see might include someone having to use pursed lips on exhalation. So what they are doing is trying to physiologically increase the positive end expiratory pressure, maintain recruitment in their alveoli when there's extra air or some other form of constriction on the alveoli. And another one we can see more often in children than we see in adults is nasal flaring on inhalation. It's a sign that used to be described as air hunger, and basically the nostrils flare or widen during the inhalation phase. Some other abnormal movements, such as retractions or indrawing around the intercostal, sub or suprasternal spaces, will be discussed in the work of breathing section a little later on in this same presentation. Other changes we can see in patterns may be due to neurological changes, such as we might see in someone who's had some sort of acquired brain injury. Typical examples include neurogenic hyperventilation or agonal breathing patterns that we might see with these head injuries. The textbook and the recommended reading list details the use of auscultation to identify both normal breath sounds and, on certain occasions when they're present, the addition of adventitious or abnormal sounds. I'll leave you to review that information, but just wanted to cover a couple of key points. Firstly, it's preferable to have the patient sitting up and, if possible, leaning forward and breathing through the mouth. Auscultation of the anterior chest wall is normally limited to the sounds that we would hear near the apices or the top of the lung and those over the lower lobes. It's done by using a bilateral comparison, that is left to right, at the points that are indicated. Bilateral comparison is also done on the posterior chest wall, so again we're comparing left and right. In this case, the apices, the midzones, the lower lobes and the bases are all auscultated in the order shown above. You can imagine that it would be a lot easier to do this with the patient's torso exposed. And I do appreciate that there's times when environmental factors and modesty may prevent this. However, it shouldn't be a standard excuse, and when it's possible to do this correctly, you should uncover the patient's torso and observe the respiratory phase as well as the placement of the stethoscope. It's really important to remember that if you're trying to listen over clothing or you're shifting the head of the stethoscope around on some people's chest walls, this can produce sounds that are very similar to the adventitious findings, and thus your diagnostic waters become somewhat muddied. The skill in auscultation is to differentiate the sounds made during the inspiratory phase from those that are made during the expiratory phase. So being able to observe the respiratory phase at the same time as listening to the chest is the easiest way to achieve these distinctions. The learning package contains links to a presentation on both the genesis and the nature of normal and abnormal breath sounds. So I'll let you review this in your own time and move on to the next point, which is around the abnormal breath sounds. Abnormal breath sounds are sometimes referred to as adventitious sounds or added sounds. They're produced by things such as a change in airway diameter or the presence of something in the airways that's causing turbulent flow, something like fluid, for instance, or on other occasions it might be due to swelling and exudate. The various characteristics of these sounds are determined by volume, by pitch, and the nature of the sound. And again, I refer you back to the links in the learning package that take you to the genesis and the nature of these sounds. But overall, crackles, and particularly fine crackles, are associated with fluid in the smaller airways. Wheeze, and particularly an expiratory wheeze, is normally associated with small airway narrowing. And bronchi, which are those sort of louder, coarser, almost snoring type sounds, are usually associated with mucus secretions in the larger airways. Another aspect in our clinical examination is examining the effort or the work that's going into someone's breathing. What we're discussing is the recruitment of muscles to assist with the movement of air in and out of the chest. Under normal circumstances, the muscle activity that maintains posture and causes the chest to expand and to collapse are pretty unremarkable. In other words, the muscle activity is difficult to observe, and even counting respiratory rate requires quite a lot of focus on occasions. Changes in the work of breathing can be due to increased or decreased muscle use. Decreased muscle use is also called hypoventilation. It might occur when someone is sedated and the rate of breathing, as well as the forcefulness of muscle activity, has been reduced. Given that normal breathing is really difficult to see, it may well be that a slow respiratory rate coupled with reduced cognition or a falling level of consciousness, cyanosis, falling oxygen saturations, or hypercarbia are going to be the primary indicators of hypoventilation. Increases in the work of breathing tend to be a little more obvious. An increase in muscle activity, the recruitment of accessory muscles, and muscle activity to alter posture is more readily observed. An increase in the work of breathing can be beneficial. A prime example is during exercise when the muscles of inspiration fire more rapidly and more strongly. This increases the respiratory rate and the depth of respiration, and it allows for the elimination of excess carbon dioxide. Posture becomes vital to maximize the chest wall movement, and it's not uncommon to see athletes adopt a position that aids the respiratory muscles. The common stances include bracing the shoulder and neck muscles to provide a better anchor for chest expansion. Interpreting the importance of increased work of breathing requires some knowledge of why it has occurred and a review of the other parameters used for the respiratory status assessment. The pathophysiology of most respiratory conditions will be an increase in airway resistance or a decrease in the availability of area for gas exchange. Increases in airway resistance, such as those that occur with asthma or obstruction of the upper airway, require a greater force to move air past or through the obstacle. This requires the normal muscles of respiration to work harder, and it's this that produces this more easily observed chest wall movement. Recruiting accessory muscles amplifies this even further and results in a more noticeable and quite often an observably tense posture. And the greater the degree of obstruction to airflow, the greater these changes will be. When this obstruction is exacerbated during the expiratory phase, such as the case with asthma, The abdominal muscles are also used to help expel air from the chest. Now, this can result in the paradoxical movement of the abdominal wall. In other words, while the patient is breathing out, the abdominal wall moves anteriorly or outwards instead of being sucked in like it normally would. Obstruction to moving air into the chest produces a different pattern, and this is what we see in severe asthma and upper airway obstructions. Breathing in normally causes the pressure inside the chest to fall. When the muscles of inspiration increase their work, the pressure drops even further. Simultaneously, as the chest is trying to expand, the spaces between the ribs gets larger. The negative pressure that's being created on the inside of the chest sucks on the intercostal spaces. This movement causes indrawing of peripheral structures like the muscle and skin below or in between the bony structures of the thoracic cage. The worse the level of obstruction, the greater the degree of indrawing is going to occur. The three places that it can be most easily seen are immediately inferior to the xiphoid process, so that's at the lower sternal border, in the lateral intercostal spaces, so as we look around each side of the patient, and also the supraclavicular spaces, and those are more easily observed even when someone has a shirt or a t-shirt on because we can just see past the collar. A decrease in gas exchange area is common with chronic obstructive pulmonary diseases, particularly emphysema. The stress that we see under those circumstances is quite often secondary to hypoxia or to hypercarbia. There are three other significant indicators associated with an increased work of breathing. One of these is nasal flaring. It's more common to be seen in pediatric patients, and essentially the nostrils flare outwards during the inspiratory phase. An expiratory grunt, this can happen in adults or in children, but it's normally an exacerbation of the processes that are used to increase the amount of physiological PEEP. Head bobbing is seen in pediatric patients. It is associated with an increase in the work of breathing, and that this increase in the work of breathing overcomes the muscle activity that would normally hold a small child's head still, so the head bobs in time with respiratory effort. Our last stop in terms of clinical skills is the use of percussion on the chest wall. Again, the reading material that we've recommended and the learning package contains some information about this. And to cut a long story short, what we're looking for is the presence of air or the presence of fluid that shouldn't be there. Air is hyperresonant, so it's going to make a more tympanic or higher pitch sound when it's percussed. It's also more likely to navigate towards the apices, and that's where we would normally look for it. Fluid, on the other hand, is very dull on percussion. It can sound a lot louder because it may transmit sound even better than what air will, but it's also likely to gravitate towards the bases. And when we're percussing, particularly with people that we think may have congestive heart failure or maybe a pneumonia, it's here that we're going to find the most significant changes. The consolidation that we get in terms of pneumonia is definitely going to be dull, but because it is so consolidated, will be very loud and readily attainable. It's also going to be confined to the affected lobes, so it can be quite a good diagnostic marker for where things are. In terms of technique, it takes a little practice, but basically you're placing one hand flat on the chest wall at the area you want to percuss, and you're holding the middle finger firmly against the wall while striking it with the middle finger of the other hand in almost a hammer-like action from the wrist. It takes a little practice, but once you get the idea, it isn't too hard to master. So I'll leave you to practice that. That draws a curtain on this part of the presentation. So over the two presentations, we've looked at what respiratory distress and respiratory failure is, the vital signs and the pulmonary markers for both distress and failure, as well as these clinical examination skills in this presentation. I'll leave you to review the rest of the material in the learning package, and if you've got any questions, don't hesitate to contact one of us. In the meantime, ka kite.